Thank you everyone for joining us for today's webinar. We're going to give everyone a few moments to log in and then we will get started. I still see a few more people logging into the webinar, so I'm going to wait about 30 more seconds and then we will start with today's presentation. Okay. Hi, everyone. My name is Nadine, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled Addressing Obesity, Feeding and Eating Disorders, and Body Dysmorphic Disorder Among LGBTQ Youth. Today's presentation, we will learn how to use culturally responsive approach to preventing, identifying, and treating obesity, eating and feeding disorders, and body dysmorphic disorder among LGBTQ youth. We will also discuss pediatric endocrinology considerations as they relate to weight gain and obesity among transgender youth. But before we begin, we have a few housekeeping reminders. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the chat icon and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A icon located in your Zoom toolbar. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed. Behavioral health issues get quick expert attention, and we all know that healthy students make better learners. Now I would like to introduce our presenter today. Alex Karoglian is the Director of Education and Training Programs at the Fenway Institute and Assistant Professor of Psychiatry at Harvard Medical School. He currently directs the National LGBT Health Education Center, a HRSA-funded cooperative agreement to improve the healthcare of LGBT people in community health centers, and the National Center for Innovation in HIV Care, also funded by HRSA. At Fenway, Dr. Karuglian also works as a clinical psychiatrist within the Behavioral Health Department and undertakes research at the Fenway Institute. He has authorized over 20 research articles, review articles, and book chapters on topics that include HIV, medication adherence, post-traumatic stress disorder, substance use disorders, transgender health, and homelessness among LGBT youth. Thank you, everyone. I will now turn it over to our presenter.
Hi, everybody. This is Alex Karoglian at Fenway Health in Boston. Are you able to see my screen? Nadine, are we good?
No, I cannot see your screen. So if you can.
Sure. I will share my screen.
Yes. Okay.
All right, are we good?
Yes, we can see it now. Thank you.
Okay, excellent. Hi, everybody. Thank you for joining us today. And our topic for the day is addressing obesity, eating disorders, and body dissatisfaction among LGBTQ youth. And we'll define what each of these terms are, as well as reviewing the relevant literature and focusing on some guiding principles in management and best practices. I have no disclosures to report. And I work at Fenway Health, which is a federally qualified health center in Boston, Massachusetts. It was founded in 1971 and essentially from its beginning has been focused on providing the highest quality care for lesbian, gay, bisexual, and transgender people. We take care of hundreds of children and adolescents as well. We have a site in Boston as part of Fenway, that's the Sidney Borum Jr. site, which takes care of LGBTQ youth as well as other vulnerable youth in the Boston area. We have an integrated care program that includes primary care along with transgender care, HIV care, and behavioral health care, all within one integrated model. And we're unusual as a health center in that we have an institute, the Fenway Institute, within our federally qualified health center that focuses on research, education, training, advocacy, and policy to advance the health of LGBT people and people living with HIV. Within the Fenway Institute, there's the Division of Education and Training, which I direct, and this includes, among other things, a national cooperative agreement from the Bureau of Primary Healthcare called the National LGBT Health Education Center. We do training and technical assistance around the country to build health programs that meet the unique needs of LGBT patients and that will hopefully reduce health disparities faced by LGBT people. We do on-site training and technical assistance where we travel to health centers and do training and assistance on site. We have a wide range of webinars we do live that are then archived on our website. We have over 50 publications and more to come focused on various LGBT health topics. All of this is available for free for you to download from our site. And we offer continuing education credits and health equality index credits for all of this. Our website is lgbthealtheducation.org. These are all the places around the country where we do training and technical assistance, from Alaska to Puerto Rico and from Maine to California. I've used this term LGBT and LGBTQ a couple of times now, and sometimes we use this term as if it's one homogeneous population where everyone has the same experiences and the same needs. The reality is, if we talk about LGBTQ youth, each of these subpopulations, the L, the G, the B, the T, and the Q, have unique experiences and unique health needs. So let's walk through this step by step in order to make sure we're all on the same page. A lot of terms get thrown around when we talk about gender identity and sexual orientation that can be really overwhelming and confusing when we first start focusing on care for this community. So let's talk through that in a systematic way. The first big point to make is that sexual orientation and gender identity are not the same thing. These are two separate experiences that people have, two separate concepts, and everyone has both a sexual orientation and a gender identity. So each of us on this webinar today have one of each, and the youth you're going to work with will each have both a sexual orientation and a gender identity. How people identify their sexual orientation or gender identity may evolve throughout their life. So you can imagine an adolescent initially identifying as straight and later identifying as gay, for example, or initially identifying as a man and later identifying as a woman, or initially identifying as a guy and later identifying as a girl, for example. Terminology also varies throughout history. So the terms that we use now are different than the concepts and terms we had 20 years ago, 10 years ago, 5 years ago, even a year ago. I hear terms from my LGBTQ youth patients that I wasn't hearing a year ago. So in the past 4 months, there are lots of new terms that I'm hearing. On our website, lgbthealtheducation.org, we have a glossary of terms related to sexual orientation and gender identity that we launched in March 2016. We had to update it 4 or 5 months ago because I'm hearing so many new terms from LGBTQ youth in clinic. What's gender identity? This is a person's inner sense of being a boy, man, male, a girl, woman, female, of another gender or of no gender. And we used to think of gender in a binary way. There were only two options, where babies were assigned one of two sexes at birth based on external anatomy. And what we now know is that those babies grow up and become children and adolescents and may have a gender identity, an inner sense of what their gender is that doesn't line up in a traditional way with the sex they were assigned when they were born. We also realize that there are more than two genders. It's not just boy or girl, man or woman. People have other gender identities that are very profound, core, fundamental parts of their identity that may not line up in a traditional way with the sex they were assigned at birth. Gender expression is how someone communicates or presents their gender to other people, to the outside world, and this can be through their behavior, their mannerisms, their speech patterns, their dress, their hairstyle. And again, this doesn't just exist in a binary way where it's either masculine or feminine. Each of us in some ways has a more masculine gender expression from a traditional standpoint, and in other ways maybe traditionally more feminine in our gender expression. And again, we don't think about this in a binary way. We, for a while, have been talking about gender identity spectrum and gender expression spectrum. And increasingly, we talk about things like a gender constellation or gender web, because it's not just boy, girl, man, woman, or something in between. There are other gender experiences people have. And in terms of people having a non-binary gender identity, it may seem like this would be a small fringe subpopulation among youth. We did a study in 2013 of 452 transgender adults and found that 41% identified as having a non-binary gender identity, neither man nor woman. And young people, youth, increasingly are identifying as having a non-binary gender identity. The younger you go, the more likely people are within the transgender community to identify that way. So this is really a substantial proportion of what folks are going to see. This is a publication we have on our website you can download for free. We did a webinar for School-Based Health Alliance on this topic about a year ago. And this is a publication to provide people with best practices and guidance in caring for non-binary youth particularly. And there are sample dialogues between providers and youth who have non-binary gender identities here. What does the T in LGBTQ mean? It refers to being transgender, and this is an umbrella term for people whose gender identity doesn't correspond in a traditional way with the sex they were assigned when they were born. So if someone was assigned male sex at birth, but identifies as a woman or girl, they may refer to themselves as a transgender woman or a transgender girl, a trans woman or a trans girl. We hear terms in the medical literature like male to female or MTF. Similarly, if someone is assigned female sex at birth but identifies as a boy or a man, they may refer to themselves as a transgender boy or transgender guy or transgender man, a trans boy or trans man simply refer to themselves as a man and say, I was a boy when I was a kid, I'm a man now, I'm no different than any other guy, so I don't identify as transgender. And we see terms in the medical literature like female to male or FTM. People with non-binary gender identities, particularly youth, often identify as genderqueer. So I have dozens and dozens of young patients with non-binary gender identities who identify as genderqueer. And then we see these terms like transmasculine and transfeminine that are inclusive of people with non-binary gender identities. They give you a sense of the direction of the gender affirmation. So transmasculine person was assigned female sex at birth but identifies along the masculine spectrum, for example. But they're inclusive of people who maybe identify as a transgender guy, but don't necessarily identify all the way as a man or a boy or a guy. In contrast to gender identity, a separate concept is sexual orientation, and this refers to how people identify their physical and emotional attractions to other people. It's helpful to think of this in three components. One is desire, and a school-based health center can really be a lifeline, an oasis for a young person, a student who maybe can't disclose their attractions to other people, to anyone in their community or to their family. So if they trust their providers at the school-based health center, that can be a lifeline and an oasis for them to finally disclose their attractions to someone else and get some support and relief and be able to process that. Behavior refers to whom someone is or isn't engaging in sexual activity with. So we use these very concrete operationalized terms like men who have sex with men who have sex with men and women who have sex with women who have sex with women and men, for example. And then there are these terms that are in the identity category. And this refers to the various labels and communities that exist in society that are associated with certain sexual orientations, and someone may or may not identify in this way. So some of the ones we're familiar with are straight, gay, lesbian, bisexual, queer, for example, which we'll talk about in a minute. And important point to make is that you can't predict how someone is going to self-identify their sexual orientation based on their behavior. So there are a lot of men who have sex with men who don't identify as gay, don't identify as bisexual, don't identify as queer, identify as straight. So we have to let people self-identify. We can't assume based on someone's sexual behavior or their sexual desire that they identify in a particular way. So why is it important to have programs for LGBTQ youth and to have tailoring of existing programs for LGBTQ youth? And I should say the Q in LGBTQ stands for a couple of things. It can stand for questioning, for a young person, for example, who's still exploring their sexual orientation or their gender identity and hasn't settled on an identity, or to refer to queer. And this is a term that used to be a slur, a put down for sexual minority people, and has now been embraced by the community, particularly younger people, to say, you can't hurt me by calling me queer. We're gonna call ourselves queer, our community, and we're gonna say it with pride so that you can't hurt us anymore by calling us queer. So that's one way in which people identify their sexual orientation, and it's much more inclusive of all sexual orientations. So why do LGBTQ youth need separate programs? Well, the Institute of Medicine and Health and Human Services convened experts, reviewed the literature, and concluded that there are clearly unique health disparities faced by LGBTQ youth. And in order to address these health disparities, we need to tailor health programs and have health systems where people understand LGBTQ health disparities and are engaged in patient-centered care in order to meet the unique needs of these youth. Important to note, LGBTQ youth are often invisible in healthcare and experience a lot of stigma. So we can't tell when someone comes to our doors if they're a sexual minority person or a gender minority person. We have to let people self-identify. And in the context of often being afraid to come out in school-based health center, for example, these are patients who are really vulnerable and have health needs that never get addressed unless we ask people to identify in terms of their sexual orientation or gender identity. And in terms of understanding the health disparities faced by this population, both from a clinical standpoint and from a research standpoint, increasingly we use the minority stress framework for LGBTQ youth. The idea is that these youth grow up with everyday discrimination, victimization, microaggressions, social isolation, and we refer to these as external stigma-related stressors, stressful things in their lives. These can lead to disruptions in general psychological processes among these youth, so in disruptions in interpersonal functioning, coping mechanisms, emotional regulation, cognitive structures that aren't adaptive, like believing it's never going to get better, nobody can be trusted, no one's ever going to love me. And then these external stigma-related stressors can lead to internal stigma-related stressors, like internalized homophobia or internalized transphobia, believing all the negative things that society has to say about someone's identity, and identity concealment and expecting rejection because these youth are so used to being mistreated by even their families. And all this stress, you can imagine, is thought to be related to what we observe in the literature, which is a much higher prevalence of various behavioral health problems among LGBTQ youth, like a much higher prevalence of depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders to cope with all the stress. And the topic of our conversation today, feeding and eating disorders, as well as body dysmorphic disorder, body dissatisfaction, and a higher prevalence of obesity, it turns out. All this stress is also associated with poor self-care, decreased engagement in primary health care, and down the road, a much higher prevalence of various physical health problems, of which obesity is one, but sexually transmitted infections and HIV infection are also more prevalent, particularly among sexual minority males and transgender women, for example. Stigma, important to think about in three categories. One of these is interpersonal stigma. This is stigma perpetrated between individuals. It can be from a member of a care team to a patient, something that starts really young. You can imagine this kid being bullied on the playground because he's perceived as being gay, and it really continues throughout the lifespan. Structural stigma refers to institutional or governmental policies that may intentionally or unintentionally restrict the opportunities of certain groups of people. One example of structural stigma that has been a hot topic in the news for over a year now is the issue of all gender restrooms and access to all gender restrooms for transgender and gender nonconforming youth. This is a challenge in schools as well as in other settings. You can imagine if you can't leave your home and safely use the restroom in public or at school, that's going to be really debilitating. I've had many trans youth who've been pulled out of restrooms and pulled out of stalls by security guards because of gender policing and them being told they don't look like they should be using that restroom. And I've met a number of trans youth who developed kidney problems because they deliberately dehydrate themselves so that when they leave home, they don't run the risk of having to use the restroom. Intrapersonal stigma refers to the internalized homophobia and internalized transphobia that comes from believing all the societal stigma that exists about your sexual orientation or your gender identity. And this can be associated with tremendous social isolation and shame that can be really hard for youth to move past, even once they start coming out as a sexual minority person or a gender minority person. So moving now to the diagnostic categories that we're interested in today, and I'm not going to get too into the weeds about adhering exactly to diagnostic criteria, but just so we all know what we're talking about and we're on the same page, one thing we're going to talk about is obesity among LGBTQ youth. And just to understand what we mean by obesity and overweight, which is another category, here are the guidelines from the CDC for obesity among children and teenagers. And you can see that overweight is defined as being in the 85th to up to the 95th percentile in terms of your body mass index. That's your weight status. Obesity is defined as being at the 95th percentile in terms of your weight status or greater. All right, so we'll talk about overweight and obesity today. The other category we were going to talk about are feeding and eating disorders. So it's not often referred to as eating disorders more broadly. In the DSM-4, these were referred to as eating disorders. In the DSM-5, they're referred to as feeding and eating disorders. And we're going to think about these broadly in terms of feeding and eating disordered behaviors. These youth may not necessarily need full diagnostic criteria to have a clear diagnosis, or they may have an unspecified eating disorder that doesn't fall into one of the traditional, more common categories. But important to have a general sense of how clinically in mental health we think about this. So this is the Diagnostic and Statistical Manual Psychiatric Disorders, the 5th edition. And eating disorders are generally characterized by persistent disturbance of eating or eating-related behavior. This results in altered consumption or absorption of food, and this occurs in a way that significantly impairs physical health or psychosocial functioning. There are diagnostic criteria for avoidant restrictive food intake disorder. Anorexia nervosa is another diagnosis. Bulimia nervosa is another diagnosis in the DSM. Binge eating disorder is an additional diagnosis, and there are a couple of others in there as well. Okay, and we won't get into the weeds with each of these. Another diagnostic category that's relevant to our discussion today is body dysmorphic disorder, and this is also defined in the DSM-5. This involves distress due to a perceived physical anomaly. So the person perceives that they have a problematic anomaly in terms of their physical appearance or shape. And they're really preoccupied with physical features they perceive as flawed, even though these flaws aren't apparent to any objective observers. And there's a repetitive behavioral component in order to have this diagnosis that's focused on the perceived physical anomaly. For example, excessively examining yourself in a mirror would be a form of repetitive behavior that would meet criteria for body dysmorphic disorder. There can also be certain specifiers to qualify the diagnosis further. For example, body dysmorphia with an obsession regarding musculature, which, as we'll discuss in a bit, is often the case in sexual minority males who have an eating disorder. And then you can qualify the degree of insight that the person has. So do they have good or fair insight into the fact that they have body dysmorphic disorder? Do they have poor insight into the fact that they have body dysmorphic disorder? Or is insight totally absent, and are they delusional, potentially? And you also have to make the case that this isn't an eating disorder, so a feeding or eating disorder. It's not that they think they're too thin or they think they're overweight, even though objectively they're not. This has to be about something. You really have to make the case that this is not a feeding or eating disorder to give a body dysmorphic disorder diagnosis. Now, we're going to think about this a little more broadly among LGBTQ youth, where we'll focus on body image dissatisfaction. So they may not meet full diagnostic criteria for body dysmorphic disorder, but a lot of people, even if they don't meet diagnostic criteria, have a really big challenge and a lot of distress due to body image dissatisfaction. So why is it that we see disparities in terms of the higher prevalence of eating disorders and shape control problems, as we put it, so controlling your body shape, among LGBTQ youth? Why do we think that this is more common? We know that it's more common because the research shows that, but what are some theories? One is that sexual and gender minority communities have specific norms about what ideal appearance is, and different ideas about the importance of appearance and physical attributes compared to other communities that aren't sexual or gender minority communities. For example, there are data to indicate that among communities of sexual minority males, like gay males, there is much more emphasis on having low body fat, having more musculature, and various other aspects of one's physical appearance. There are also data to indicate that among sexual minority female communities, for example, there's a higher tolerance of and acceptance of people being overweight than there is in the general population among women who aren't and females who aren't sexual minority. So part of it is thought to be related to community norms. And a big part of it, we just talked about minority stress, is the idea that there are stress-induced responses to chronic experiences of victimization, discrimination, and internalized stigma that sexual and gender minority people experience. And all that stress in response to stigma, victimization, discrimination is something people cope with or respond to through disordered feeding and eating, as well as unhealthy shape control behaviors. Now, focusing on obesity, there are a couple of populations within the LGBTQ youth broader community that disproportionately experience obesity. Studies indicate that sexual minority females are more likely to be obese than their counterparts. There are some recent findings, and recently published in the past 3 years, that demonstrate an association between discrimination and either being overweight or being obese among lesbian-identified females. So it really is this connection between discrimination and being at a problematic weight. And lesbian-identified females may engage in various negative health behaviors like binge eating to cope with discrimination. So this has also been shown in a recent study. Internalized homophobia, being conscious of the stigma around one's sexual orientation, and concealment of one's sexual identity are associated with increased binge eating through maladaptive coping behaviors, social isolation, and low mood or negative affect, as we say in the mental health clinical field. There was also a qualitative study done in 2010 that showed that lesbian-identified females were more likely to mention that depression and minority stress interfere with their ability to eat healthy and to exercise. Another study found that young partnered lesbian-identified females had an overweight status or obesity, were more likely to have this if they had more public lesbian identification, so if they were more out about their lesbian identity, if they had depressive symptoms, if they had heavy alcohol consumption, if they were in relationships longer, but also if they had lower relationship consensus. So if there was more disagreement within their romantic partnership, their romantic relationship, and more conflict, then they were more likely to be overweight or obese. So important to realize that when we think about weight control among sexual minority females who may be overweight or obese, that binge eating is an important component to focus on. This seems to be mechanistically associated in studies with overweight status and more so than other behaviors, eating behaviors. Important to determine the triggers for binge eating behaviors, including whether stigma related to one's sexual minority identity is associated with binge eating and is a trigger for that. And essential for school-based health centers to create environments that are safe for sexual minority youth who are female identified to be able to discuss their identity and the challenges related to their identity, to discuss the challenges related to being out and whatever stigma they experience for that with their care teams within the school-based health center. And really key for us to focus our prevention and intervention efforts for binge eating on this adolescent development period for what we often describe as transitional age youth, or youth where we can really change the life trajectory. If we're intervening early and addressing any kind of minority stress experiences that people are having, giving people coping skills and resources, we can really change the trajectory in terms of obesity and physical health among sexual minority females. So binge eating has repeatedly been found to be a salient predictor of being overweight or obese, and this is even after controlling for various demographic variables, how out someone is about their sexual identity, controlling for diet, and controlling for physical activity. So there really seems to be this binge eating component. Important to have culturally competent obesity interventions and health promotion programs, and to think about the fact that if we're trying really hard to engage in weight control practices and interventions and promote health in this regard with young sexual minority females, that if we're not focusing on binge eating behaviors, screening for this, and then addressing it when it's present, we may be missing part of what will make our efforts more effective. If we think about other LGBT subgroups and LGBTQ youth, more than 50% of each LGBT subgroup generally reports body mass index in the overweight or obese range. So this is really alarming that we see very high prevalence of obesity in this community. Nearly half of transmasculine patients report a BMI in the obese range. So this is really alarming as well. I was having dinner a couple of nights ago with the medical director of the GEMS clinic, Gender Management Services Clinic at Boston Children's Hospital, which is the sort of legendary first practice that really pioneered a lot of our understanding and clinical work related to transgender youth. And Dr. Carswell, who directs the clinic, was telling me she sees very consistently that when she starts patients on masculinizing hormone therapy, testosterone, these transmasculine youth assigned female sex at birth tend to gain a significant amount of weight. And we don't really understand why. So further research is needed to examine the potential impact of various factors related to transgender experience, including gender-affirming hormone therapy, gender-affirming surgeries. There are differences in terms of age of gender affirmation on the likelihood of becoming obese. There is also anecdotally something we hear about people finding that weight gain may visually conceal secondary sex characteristics. So for transmasculine people finding that they appear less feminized if they're obese. I haven't seen any studies to substantiate that, but that's something that I've certainly heard from young patients of mine, and that other providers will report discussing with their patients as well. This was a study looking at transgender students, and compared to non-transgender students, transgender students are more likely to be either underweight or obese, so it can go in both directions, are less likely to meet recommendations for strenuous physical activity, strengthening physical activity, and screen time, so spending a lot of time watching TV or on the computer. And there are some studies that indicate that trans feminine youth are more likely to be underweight, and we see certain kinds of unhealthy shape control behaviors among trans feminine patients, and really disproportionate overweight status or obesity among trans masculine patients. Transgender students may need to be more targeted with tailored, customized, culturally appropriate interventions to alleviate this existing disparity and improve long-term health. So providers need to deliver the weight loss or weight gain messages that they normally would, but in a way that's really grounded in an understanding of cultural competence that's needed for transgender students, and to be sensitive to and affirming of gender needs and gender expression. Otherwise, you really risk alienating these youth and not forging a therapeutic alliance that's going to result in better outcomes. Now, if we look at eating behaviors among sexual minority male youth, there's often a lot of stigma and lack of engagement in treatment for eating disorders among sexual minority males. So being a male with an eating disorder often carries even more stigma in some respects than being female and having an eating disorder, because it's a set of disorders or problems that are traditionally viewed as something more likely to be experienced by females. But males with disordered eating, and certainly this being something that's quite common among sexual minority males, require treatment as much as anyone else with an eating disorder. The prevalence of eating disorders among sexual minority males is found in a number of studies to be about what it is in among women in general and among females in general. Often these disordered eating behaviors are muscularity oriented, so eating way too much protein, for example, and some of the behaviors in that regard can be a little different from what we see among females. A distinct array of medical complexities have been found in the research. For example, males with disordered eating are more likely to have elevated liver enzymes than what we see among females. Symptom presentation may differ from what we see among females. For example, this focused on very high protein foods. And studies have found that sexual minority males with eating disorders are less likely to receive an eating disorder diagnosis even when they have one than their female counterparts, and are more likely to experience delay in seeking help, and are more likely to have entrenchment in their illness. So these can really be quite refractory, and eating disorders tend to be challenging to treat in the first place. Compared to their peers, sexual minority males are more likely to display body image concerns. So compared to other males, sexual minority males are more likely to have body image concerns related to weight and shape, muscle tone and definition, are more likely to engage in binge eating, more likely to engage in purging, more likely to have restrictive dieting behaviors, more likely to use diet pills, and more likely to misuse anabolic steroids in order to bulk up and have more musculature. Body dissatisfaction is a big problem among sexual minority males. Body dissatisfaction predicts higher depressive symptoms, lower sexual self-efficacy, and elevated sexual anxiety around one's sexuality and sexual behavior among sexual minority males. So body dissatisfaction is really related to worse depression and worse sexual health and psychosexual health, as we say. Given this high prevalence of body image concerns among sexual minority men and these findings, depression and HIV or sexually transmitted infection prevention programs may really benefit from having more routine assessment of possible body dissatisfaction, so screening for this, and intervening with those who report concerns. So really important to think about screening systematically for this among sexual minority men and to intervene accordingly. There's also been some compelling and alarming research around misperception of one's own weight and unhealthy control behaviors among sexual minority youth. So sexual minority males are more likely to see themselves as overweight despite being of healthy weight or underweight. And sexual minority females are more likely to self-perceive as being of a healthy weight or underweight, despite actually being overweight or obese. So this is the difference between sexual minority males and sexual minority females in the same study. And unhealthy weight control behaviors were significantly more prevalent among both sexual minority males and sexual minority females. So fasting, pills, vomiting, laxatives were more prevalent among sexual minority youth than among other youth. So recommendation from this same group was that treatment during high school or earlier may prevent any downstream adverse effects on growth, bone density, and reproductive function. And so again, this idea of intervening when we can change a young person's life trajectory. And this is really an opportunity we want to take advantage of, and school-based health centers are so well positioned to do this for sexual minority youth. There are some compelling interventions being developed to address body image concerns and self-care among sexual minority males. So this is one, it's called Cognitive Behavioral Therapy for Body Image and Self-Care, CBT-BISC. This is a tailored 12-session manualized treatment that integrates traditional cognitive behavioral therapy protocols for body image disturbance with sexual minority stress principles. So incorporating all those ideas we talked about in that minority stress framework and all the triggers that come with being part of a sexual minority person, being a sexual minority male, and all the stigma that comes with that, incorporating that into existing cognitive behavioral therapy protocols for body image disturbance. And in this study, it was found that sexual minority males who had this treatment showed substantial improvement in body image disturbance, depressive symptoms, physical self-care, and global functioning, compared to those who didn't receive this intervention. Now, focusing on transgender youth and gender-affirming care and how that's related to eating disorders. There is thinking increasingly that elevated risk for eating disorders among transgender youth may be related to body dissatisfaction and the kind of societal reactions that transgender people experience related to their gender nonconformity, their gender expression that's outside of societal norms, and the chronic lack of affirmation in that regard. For example, misgendering, being referred to in a gender other than one that corresponds to your identity. For example, people using incorrect pronouns even after you've made it clear to them what your pronouns are and how you identify. So this interesting study found that genital construction surgery, chest construction surgery, gender-affirming hormone therapy, hysterectomy, and hair removal reduced experiences of gender non-affirmation. So lead to people, these gender-affirming medical and surgical procedures increase the experience of gender affirmation, increase body satisfaction, and thus seem to decrease disordered eating symptoms. So really important to think about gender-affirming medical care as something that improves mental health for this population, for transgender youth. Transgender people have greater body dissatisfaction than control participants in another study out of the United Kingdom, and transmasculine participants have comparable body dissatisfaction scores to cisgender males with eating disorders. So just at baseline, transmasculine participants in this study had the kind of body dissatisfaction we see normally with someone who has an eating disorder. And the drive for thinness was greater among trans feminine participants than transmasculine participants in this study. Interestingly and concerningly, if you think it might just be related to the fact that people haven't had their gender affirmed yet and that's why they have body dissatisfaction, the reality is in this study, transmasculine and trans feminine participants reported greater dissatisfaction, not only for gender identifying body parts, so not only related to primary, secondary sex characteristics, but also body shape and weight in general. So the greater body dissatisfaction in transgender people compared with the general population isn't just about sex characteristics, it's body dissatisfaction more broadly than that. These are the DSM-5 criteria for gender dysphoria, which exists for children and adolescents as well as adults. So marked incongruence between one's experienced or expressed gender and assigned gender of at least 6 months duration. And this condition is associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning, with significantly increased risk of suffering. So important to understand that we used to say, well, not me personally, but our field, mental health field, used to say, we're going to wait until someone doesn't have any co-occurring psychiatric problems, until every mental health problem is in remission before we take this gender identity issue seriously. And now we know that that's not ethical and not effective. So the best practice is that we need to make every effort to stabilize co-occurring mental health problems among gender diverse youth and people in general, in order to allow gender diverse youth, transgender youth, to move forward with a very important and urgent process of gender identity exploration, discovery, and treatment. So if someone is a gender diverse person, we don't try to stabilize, for example, the eating disorder first before we move forward with gender affirming medical care. As we saw from the previous couple of studies, gender affirming medical care will often lead to resolution, hopefully, of disordered eating behaviors and other body dissatisfaction. So we don't want to put the cart before the horse, right? It's really important to think about every effort to stabilize co-occurring disordered eating, and also in parallel with that, be moving forward with gender affirmation, and hopefully the gender affirmation will help with body satisfaction and eating behaviors down the road. The World Professional Association for Transgender Health, or WPATH, calls for reasonably good control of co-occurring physical and mental health problems. So we don't expect for people to be in remission in order for them to move forward with gender affirming medical care. We don't want to gatekeep in that way. Our field has a somewhat sordid history of unnecessary gatekeeping that's been very damaging in terms of mental and physical health for transgender youth. So in terms of affirming people's gender in a way that will reduce the minority stress that they experience and hopefully help in at least one way to improve their overall mental health, pronouns are very important for transgender and non-binary youth. Some pronouns we're all familiar with already, like he, him, his. Other pronouns that transgender or non-binary youth may use include they, them, theirs in the singular. I increasingly have dozens of non-binary, genderqueer youth as patients whose pronouns are they, them, theirs. And we use that in the singular, which takes some practice, but it's now officially in the dictionary as a pronoun in the singular. So we would say they are in the waiting room, the doctor is ready to see them, that chart is theirs. And youth increasingly have new pronouns that didn't exist before that are specifically for non-binary identities, like Z, here, here's. Z is in the waiting room, the doctor is ready to see here, that chart is here's, for example. And again, these take practice. So what's our role as behavioral health clinicians in the gender affirmation process? We really want to help foster gender identity exploration, discovery, and affirmation. We want to present appropriate non-medical and medical strategies for gender affirmation. We want to assist our patients in making fully informed decisions regarding their personalized gender affirmation process. And if they have, if they're not of age of majority and have a guardian or a parent who's helping to make these decisions, we want to really present all these options, help them weigh the risks and the benefits and really educate them about these, and evaluate the capacity for medical decision-making and informed consent. It's really an informed consent model, and arrange suitable referrals to care. In addition to helping folks explore, discover, and affirm their gender identity, expression, and role, we want to help them focus on reducing internalized transphobia or internalized homophobia, so undoing a lot of that internalized stigma that society very insidiously can lead to young people experiencing. We want to help improve body image, and even as we're helping transgender people undergo body modifications in order to have a body that matches their gender identity and that they feel comfortable and affirmed in, young people may have fantasies about how masculinized they'll be once they start on testosterone, or how feminized they'll be once they start on feminizing hormones like estrogen. So while we're helping people be affirmed in these ways, we also want to help them have realistic expectations, which are often related to their genetics. You know, you're going to be as masculinized or feminized as your genetic predisposition allows you to, and there are a range of other factors associated with that. So we really also want to help people accept who they're going to be physically and otherwise when they are affirmed in their gender. And we want to help people facilitate their adjustment throughout the affirmation process. So youth often, don't necessarily have a lot of experience or ability to think through in a granular way how their life is going to change in every possible domain as they go through this gender affirmation process. So physical changes, psychological changes they'll experience, social changes, sexual changes, changes to their reproductive capacity and fertility that really need to be discussed carefully, economic challenges that'll come up, and legal challenges. So in terms of treating eating disorders among LGBTQ youth, generally important to say this is really challenging. This is one of the harder things to do, I think, within the mental health field. And luckily, there are evidence-informed treatments that exist that work well. Not everyone is trained to deliver these evidence-informed treatments with high fidelity to the original model. So it's really important to refer people to evidence-informed treatment for eating disorders if you want to get traction and really help people get better. Some examples are enhanced cognitive behavioral therapy for eating disorders, CBTE. There's family-based treatment, FBT, interpersonal therapy, IPT, dialectic behavioral therapy that's been adapted for eating disorders. So there's DBT, which is normally for emotional regulation and skills and was originally developed for borderline personality disorder. It's been adapted for eating disorders as well. And really important for all clinicians involved at the school-based health center and more broadly to be attentive to the unique sociocultural experiences that LGBTQ youth have, to be thinking in terms of minority stressors and all the ways in which sexual minority stress or gender minority stress may be a trigger for unhealthy shape control and disordered eating behaviors, for example. Thinking in terms of minority stress treatment principles more broadly with this population when doing work around weight control, disordered eating, body dissatisfaction, to normalize the adverse impact of sexual and gender minority stress. So often LGBTQ youth will attribute challenges in their life to personal failings rather than the minority stress that they experience on a day-to-day basis, which sometimes is subtle and we're not even aware of. So important to name that with these youth so that they more accurately attribute their personal challenges to this minority stress when appropriate. And that can be a very liberating experience. Facilitating emotional awareness, regulation, and self-acceptance, which are things ideally we would be doing with all youth and can be a particular challenge for these youth to achieve in the context of all the minority stress they experience. Helping to restructure minority stress cognitions like it's never going to get better, no one's ever going to love me, no one can be trusted. So trying to introduce some cognitive flexibility and more adaptive beliefs in that regard. Validating unique strengths of LGBTQ youth. This is a community that's overcome tremendous challenges, and when people feel connected to the strength within their community, that can be really empowering. Fostering supportive relationships and community, both within the LGBTQ community as well as with allies, and having adult mentors from the LGBTQ community who can really help affirm these youth and realize that things can get better over time. And affirming healthy, rewarding expressions of sexuality and gender in a way that will help people feel affirmed, reduce the kind of minority stress that's experienced, and hopefully contribute to better self-care, which is really what we're talking about today. Really key to appreciate on our end the tremendous resilience that LGBTQ youth have, and for them to feel connected to the resilience of this remarkable community that they're part of, that's achieved tremendous milestones and strides in terms of rights nationally and around the world, and mainstream acceptance increasingly in society, and feeling the connection to that resilience and capacity to overcome within the broader LGBTQ community can be a real lifeline and source of strength and motivation to go on for these kids. Thank you so much for your time. We have a few minutes for questions, and this is our website for the National LGBT Health Education Center, lgbthealtheducation.org. Please feel free to visit us and be in touch with any questions or requests for training and technical assistance moving forward. Thank you.
Thank you very, very much, Alex, for this presentation. So now we would like to take everyone's questions. If you currently have questions, feel free to input your questions in our Q&A box on the Zoom control toolbar. So while we give everyone an opportunity to answer their questions, we do have a few announcements. All right, so I do want to give you guys a little bit more information about our membership. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based healthcare. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking opportunities. Please take a moment after the presentation to visit our website using the link on your screen for more information and to join. So let's talk data. You can now complete your national school-based healthcare census and report the national school-based health, care performance measures through our census portal. So please take time to get more information on our website and enter your data today. Our 2018 convention will take place on June 24th through the 27th in Indianapolis, Indiana. So please save the date and we look forward to seeing you there. So I just want to look through to see if we have any questions. I do not believe we do. So I do want to I have a few questions for our attendees. So please complete the poll that you currently see on your screen. I'm going to give you guys a few more minutes to answer these questions, and I see something just popped up in our Q&A box. So once we're done with this poll, we will definitely get to your question. Okay, so while people are doing the poll question, I do want to share the question that was asked, Alex. I have a question that asks, is it common or uncommon for Medicaid insurance to cover some of the medical procedures for youth you discussed?
Great question. It's increasingly common. Several states have laws prohibiting exclusion from insurance coverage for gender-affirming medical care. So in Massachusetts, for example, where I am, since 2014, there's been prohibition of exclusion for insurance coverage for gender-affirming hormone therapy and gender-affirming surgery. This is true in many states. Insurance companies increasingly are providing this care or covering this care. And the American Medical Association since 2008 has determined that gender-affirming hormone therapy and surgery are medically necessary treatments for transgender patients. And the Affordable Care Act has protections under Section 1557 that have been interpreted to be based on gender identity. And there are also protections to not be able to discriminate against transgender people in having transgender status be a pre-existing condition. So it is something that increasingly there is consistent insurance coverage for. Hormone therapy more than surgery, but it is also the case for surgery increasingly. And we have a transgender patient advocate at Fenway whose job is to appeal decisions by insurance companies and get coverage for surgery.
Great. Thank you very much for that answer, Alex. I'm going to give about 30 more seconds for our poll. Our attendees are now viewing questions, so please feel free to answer these questions. Oh, wait, and we've got another question. All right, so Alex, for those school-based health centers with mostly or only primary care, when do you recommend trying to assess some of what you're finding? Like, so the child care visits, etc.
Yeah, well, there are a couple of pieces to it. One is in terms of assessing for gender identity and sexual orientation, or asking those questions, sexual orientation, gender identity questions, we recommend asking about sexual orientation. Many places start that around 12 years old. So when you're starting to have conversations about sexual health with youth, and when you'd be having those conversations with anybody, to also be asking, what are the genders of the people you're attracted to, who you're attracted to, that kind of thing. In terms of gender identity, that often becomes clear quite young as 4 years old or 3 years old. People have a clear sense of what their gender identity is. So those questions, or paying attention to that, and gender identity development and sexual orientation, quite young for gender identity, and about 12 we start having those conversations for sexual orientation, although there are 9-year-olds who identify as gay too, so it can come up earlier. In terms of screening for obesity, certainly that's something we're doing anyway, right? Hopefully within a primary care context for children and adolescents. So you would do that when you're normally doing it. In terms of disordered eating, we see that happening very young. I've seen 8-year-olds on inpatient specialized eating disorders units who have terrible eating disorders. So you want to be screening, as part of well child visits, for what kind of dietary behaviors these children and adolescents have. And body satisfaction conversations are ones you can start having with children very young, from the time they're able cognitively to have those conversations with you.
Okay. We have time for about one more question. Someone asked, have you seen or heard of any success with health centers running peer support programs for LGBTQ youth, either obesity-based or focused on other needs?
Great question. I haven't seen, so yes, I have seen a lot of success with support programs for LGBTQ youth, and those come in a lot of different forms, group programs. And I have seen some specifically focused on mental health, where body image and eating disorders are a big focus, among others. I haven't seen one explicitly around obesity. I've seen obesity kind of folded into that, where it's a broader mental health focus or self-care focused. And these tend to be very well received by LGBTQ youth, who enjoy the solidarity, as well as getting a lot of good ideas and reinforcement around healthy self-care.
Okay, thank you very much. All right, so that actually concludes our webinar today. So we want to thank everyone for attending, and our sincerest thank you to our presenter, Alex. Thank you very much.
My pleasure. Thank you so much. It was fun.
Thank you.